Welcome, this is Combat Medic Prolonged Care, a course about what happens when the casualty cannot leave and the care has to continue where you are. This is a knowledge and reference course for combat medics. It is not a substitute for hands-on training, and it does not replace your unit's medical direction. It assumes you already work at combat lifesaver level or above. The emergency sequence, bleeding control, these basic skills should be second nature. These videos prepare you for the in-person classes, and afterwards they work as a reference. One module, one subject, when you need to look something up. The golden hour did not disappear because bodies changed, but because the environment changed. Helicopters cannot fly into a sky full of anti-aircraft fire. Roads are watched around the clock. Marked medical transport has been attacked, so movement waits for darkness, for weather, for a corridor. Field hospitals sit further back, out of artillery range. None of that is a failure of planning. It is the modern, large-scale battlefield. Waits of 72 hours and longer to surgical care are documented. So the question is not whether you will hold a casualty, it is whether you will do it well. Look at the two timelines. The older model: injury, a short hold, a helicopter, surgery within the hour. The contemporary picture: an uncertain route, movement in windows, a surgical team perhaps 100 kilometers away, and hours, sometimes days, in between. That gap in the middle is this course. Everything from Module 2 onwards lives inside it. Make delayed evacuation your planning assumption from minute 1. You rarely control the route or the movement decision, so never promise the casualty a time you do not own. Build the hold early. Warmth, access, a record, a rhythm. If the vehicle then arrives in 20 minutes, wonderful, you have lost nothing. If it arrives tomorrow, you are already running a system instead of improvising one at 3 in the morning. The phases do not change. Care under fire, then tactical field care, exactly as you trained them. When evacuation is delayed, the hold begins. The same casualty, at the same position, with care running as a loop. Reassess, treat, document, and again. Tactical evacuation closes the chain whenever it becomes possible. The emergency sequence is a line, the hold is a loop. Most of this course is about running that loop well. Prolonged care does not replace the sequence. March, pause, NL remains the spine of everything we do. What changes is depth and repetition. Each intervention now has an endpoint, a recheck, and a written trace. Because in a long hold, the second look matters as much as the first treatment. After the first hour, the work becomes less dramatic, but not less clinical. Your job becomes detecting direction, better, worse, or unchanged. A tourniquet that was right at minute 5 needs a decision at hour 3. A dressing that was dry at midnight needs eyes at 2. The skill of the long hold is noticing the change before it becomes the emergency. The name states the ambition, not a promise. The Golden Week is a capability framework. The trained window is the first 48 to 72 hours, and it scales with what you carry and what can be brought to you. The same doctrine in a rucksack, a vehicle, a house, or an aircraft. You will meet that idea again in the logistics module. These 5 are not a list of causes of death. They are recurring failure modes that grow more dangerous as the hold lengthens. Bleeding that returns, shock that deepens quietly, the airway that was fine while the casualty was awake, the cold that creeps back in, the infection that starts on day 1 and declares itself on day 3. Each has a module later in the course. Notice that none of them announces itself. That is why the course keeps returning to rhythm and reassessment. The first error is treating rapid evacuation as the rule and the long hold as a surprise. The second is promising arrival times you do not control. It costs you the casualty's trust when the vehicle does not come. The third is running the first hour brilliantly and then stopping. No rhythm, no record, no plan for the night. The course exists because these errors are normal. Systems beat willpower. One distinction to carry through all 23 modules. Training and authority are different things. This course provides training, not licensing. The protocol marker, P in brackets, identifies skills that require written medical direction before use: injected drugs, decompression, the surgical airway, urinary catheters, burn resuscitation. Provider level marker means thoracostomy and chest drains. You learn to recognize, assist, and maintain. Blood requires its own approved protocol. Local approval, case by case, or in local guidelines. You will see the markers. The authority slide will not be repeated. 3 ideas from this module. Delayed evacuation creates an active clinical phase, and the system for that phase is built early, not improvised late. March, pause and L remains the spine. The hold changes depth and repetition, not order. And trained is not authorized. The markers carry that rule from here on. The sources for this module are on screen. Module 2 takes the spine itself, the sequence, and how the whole course is organized around it.